Hello and good evening, everyone. Welcome to the Cottage Center for Orthopedics Meet the Doctor, featuring Dr. Thomas and Dr. Birch, orthopedic surgeons affiliated with Cottage Health. I'm Christina Cortez, Public Relations Manager for Cottage Health, and I'll be your event moderator today. So thank you all for joining us. Before we get started, I'd like to review a couple of housekeeping items to optimize your experience in this webinar. At the conclusion of this presentation, we will host a brief question and answer session. Please use the Q&A button at the bottom of your screen to ask a question. This presentation is being recorded, so you will receive an email within the next week with a link to view the presentation and PowerPoint slides. It's now my pleasure to introduce Dr. Danielle Thomas and Dr. Chris Birch. Dr. Thomas is an orthopedic surgeon with subspecialty training in foot and ankle surgery, practicing in Santa Barbara at the Ryu Hurwitz Orthopedic Clinic. Dr. Thomas is an expert in using surgical, non-surgical, and minimally invasive techniques to maximize patient function. She also has extensive experience in caring for trauma patients and managing broken bones. Dr. Birch specializes in adult reconstructive orthopedic surgery with a focus on primary and revision hip and knee arthroplasty. He is skilled in minimally invasive total joint arthroplasty, as well as advanced techniques in managing complications of failed or painful hip and knee replacements. He performs total hip replacements through all surgical approaches, and together he and the patient decide which option is best for each individual. So without further ado, please join me in welcoming them both.
Well, good afternoon. My name is Chris Birch. Hope you can hear me okay. As mentioned, I'm an orthopedic surgeon with Alta Orthopedics. We are a group of 9 surgeons with offices in Oxnard, Santa Maria, Solvang, and Santa Barbara. I primarily focus on hip and knee replacements and fracture care, and I'm here joined with Danielle Thomas. We're going to go through this outline, talk about options prior to surgery, how to make a decision for surgery, some of the things to think about around the perioperative time during surgery, and recovery and function after surgery.
And I'm Danielle Thomas with the Ryu Hurwitz Ortho Clinic, 5 orthopedic surgeons with offices in Santa Barbara and Santa Maria.
So I'll now discuss treatment options to reduce pain and restore function that we generally recommend trying prior to surgery. We'll break this conversation down in treatments available to you, like maximizing non-operative treatments, and ways that you yourself can optimize yourself medically and with your lifestyle to prepare for surgery. So we'll start with the bread and butter. Maximizing non-operative treatments, starting with over-the-counter medications. Simple Tylenol, also known as acetaminophen, is readily available over the counter and quite effective in multiple clinical trials, helping with arthritis and musculoskeletal pain. Similarly, NSAIDs, or non-steroidal anti-inflammatories. Examples of these would be Advil, ibuprofen, Aleve, naproxen are also available over the counter. There are some prescription forms of these, such as meloxicam, diclofenac, or celecoxib, that are generic but prescription strength anti-inflammatories. These also are very helpful, maybe more helpful than Tylenol, in helping reduce pain for orthopedic conditions. Specific to the NSAIDs, there can be contraindications such as coronary artery disease, chronic kidney disease, or history of stomach ulcers. So something you should discuss individually with your primary care doctor or with your orthopedic surgeon if they're prescribing them. Similar to oral NSAIDs, topical anti-inflammatories such as capsaicin cream or Voltaren gel are available to apply directly to the area that you're having pain. These are similar to oral NSAIDs and probably should not be taken at the same time, but can be very effective at localized control of any painful area. So over-the-counter medications also include vitamin supplements and more naturopathic supplements such as arnica and turmeric. These can be found in pill form or capsule form at health food stores and some pharmacies, but also can just be taken as whole food and be part of your diet and have shown to have anti-inflammatory effects. Glucosamine and chondroitin have been around for a long time. These are ingredients that are part of our collagen makeup, which is what makes cartilage in our bodies. Is an oral supplement that actually has not been shown to have very good evidence at reducing joint pain and helping with function with musculoskeletal ailments. That said, anecdotally, a lot of patients have found them to be helpful, and they have a very low side effect profile, almost no risk in taking them outside of your pocketbook. So I do encourage people to try glucosamine and chondroitin because I've had a lot of patients have success, even though the evidence in scientific studies has not been strong. Dr. Thomas, do you want to mention about vitamin D?
Yeah, I would add the importance of making sure your vitamin D is adequate. We know that between 20 and 60% of orthopedic surgery patients are low or almost clinically deficient in vitamin D, especially in foot and ankle surgery. Anytime we're working on bones, including fusions and fracture surgery, it's crucial to make sure that your vitamin D is sufficient.
Excellent. So moving on to opioid medications, regularly referred to as narcotic medications, are prescription controlled substances that can be taken orally or intravenously. Some familiar names are Percocet, Norco, hydrocodone, oxycodone, and even tramadol, which in my practice is often thought of more of as an anti-inflammatory, but is actually in the opioid class of medications. This has been well studied, and as you know, you hear about opioid medications regularly in the news media, and has been shown time and time again to not really be an effective long-term treatment to help control pain around arthritis and other musculoskeletal problems. If you do take opioids on a regular basis, or you do find them to be helpful for you, I would add that there is a significant benefit in titrating down or reducing the amount of opioid medications you take prior to considering surgery. That allows our body to become more sensitive to these medications, and we do use them after surgery to help control pain. So for my patients that are on higher doses or regular doses of opioid medications preoperatively, we try to wean down the dose or reduce the dose prior to surgery. So similar other medications that are injectables, classically we talk about cortisone, but there are multiple options out there. These are medications that we're actually injecting into the soft tissues or into the joint in the painful area. Classically, we discuss cortisone, viscosupplementation, and something called platelet-rich plasma. So they all work differently on a biochemical level, but they all essentially reduce pain and reduce inflammation in the affected area. So it's the goal, the end goal of all of these different injection medications is the same, and that we're trying to reduce pain and restore function. They just work differently. The oldest, kind of the gold standard of injections in orthopedic care, is cortisone. It tends to work very quickly, but not last very long. So it can be effective for flare-ups of arthritic joints or for kind of acute injuries of chronic conditions to try to get the inflammation to calm down. Viscosupplementation has a lot of synonyms that people have heard. It's known as rooster injections or gel injections or hyaluronic acid injection therapy. The reason we call it hyaluronic acid is because that is the biochemical makeup of the drug, which is an ingredient of our collagen. It was initially used as an injection in hopes of trying to build back the cartilage in an arthritic joint or a worn out joint. And it never showed to really do that, but it has helped as an anti-inflammatory medication in the affected area. Cortisone can be used in the soft tissues and around tendons and in joints, but viscosupplementation or hyaluronic acid tends to be used only inside arthritic joints, and that's what it's FDA approved for. It's usually a series of injections given multiple times once a week for multiple weeks. Platelet-rich plasma is in a class of injection therapy called biologics, meaning using natural human or animal tissue as a natural anti-inflammatory, unlike something that's manufactured in the lab. So platelet-rich plasma is your peripheral blood. It's drawn out of your vein, just like when you're giving blood at the lab. It's spun down in a centrifuge machine, and the white cells and the red cells are removed, and it leaves the plasma portion of your blood. That portion is rich in mesenchymal stem cells, growth factors, anti-inflammatory cytokines, and other things that can reduce pain and inflammation in the joint. I'll say, maybe go back a slide. Some of these injections are covered by insurance and some are not. And some are covered by some insurance plans and others not. So that's a conversation you're gonna have to have individually with your provider.
Bracing is another option for optimizing non-operative management of painful joints. This can look like braces that you get off the shelf at your local drugstore, or it could be something that's custom fit to accommodate a specific deformity or a specific need. This can include anything from orthotics that you use on your feet to accommodate different foot architecture, braces about the ankle sprain braces, stability braces, all the way up to something like a custom Arizona brace, which is a rigid leather brace that's used to mimic what an ankle fusion would feel like by removing any motion about the ankle. Similarly, in the knees, braces can be used just for compression and for some neuromuscular support and education, all the way up to something like an offloader brace or hinge knee brace that has specific targets for range of motion and specific pressures that it is applying to the joint to take weight off specific parts of the knee. So these are often helpful in temporizing timing to surgery. If it's not a convenient time for a patient to have surgery, given their family life, or if their other health concerns are not optimized, this is a great tool.
All right, walking aids can similarly be very helpful. They reduce the force on your arthritic joint and therefore reduce pain. They also have the added benefit of helping with balance and reducing fall risks, which are laudable goals. So I strongly recommend them for lots of patients. For my active patients who travel and who hike and who walk long distances, I think trekking poles can be a great option. They seem to be more ergonomic, meaning that they fit into your hand better and keep your arm at a resting length next to your side, as opposed to lower down with a cane. They also sell really cool trekking poles these days that are very light and telescope down, that are easily put in a purse or a backpack or when traveling. So I think trekking poles are a great option. So we kind of classified this area under the general form movement, because there's a lot of different options for keeping walking and keeping moving with orthopedic ailments. We divide it into neuromuscular training, which is things like improving your walking speed, improving your endurance, working on balance and muscle tone. This often includes weight training and specific strengthening exercises around the diseased joint or extremity. This can be done with an athletic trainer or a physical therapist, or there are actually a lot of modern kind of app-based programs that will help you with some of these things. So there's a lot of options outside of traditional physical therapy. However, we all think that traditional physical therapy plays a vital role before and after surgery. In addition to specific neuromuscular training, exercise alone has actually been shown to reduce joint pain and improve function in the arthritic joint. And when surveys have been taken after exercise programs have been done in studies, that patients have higher satisfaction scores with just exercise alone. So it can be a difficult conversation that we have with our patients, because the painful ailment in your musculoskeletal system sometimes is preventing you from participating in exercise, yet participating in exercise can actually reduce your pain and make you feel more functional in the long run. So it's a balance, but we highly encourage people to move on their orthopedic conditions. That, in addition, a lot of patients are concerned that they're going to cause more damage to the joint if they walk on it too much or do too much exercise on it. And a majority of the time, the answer is no. It's not never, but most of the time, you're not going to make things worse by strength training, exercising, and walking. Dr. Thomas, you want to touch base on prehab?
Yeah, absolutely. And before I do, I'd just like to add, one of the benefits of the neuromuscular training and exercise is that you're maintaining bone density, which is so crucial, especially in the post-op period. Prehab is a term that refers to doing some physical therapy and training for your surgery. It has a lot of benefits. One being that you get to make a relationship with a physical therapist and get to know the person who's going to be working with you potentially after surgery. And you are preparing for your specific surgical needs. In foot and ankle surgery, most patients do have a period of needing to be non-weight bearing or partial weight bearing after surgery. And so this is an opportunity to prepare the good leg, to strengthen upper extremities, to strengthen the core, and also to figure out what movement aids or durable medical equipment, such as a knee scooter or a cane or the walking sticks that Dr. Birch talked about, what works for you in your home, and actually try those out before you have a surgical wound and a potentially complex surgery that you're trying to protect. So you get to practice and prepare and strengthen for your surgery.
So we're going to transition away from maximizing treatments that you can pursue or obtain towards how you can optimize your own health, both medically and with your lifestyle.
So with thinking about getting healthy, with medically optimizing your body for surgery, you may need to gain weight or you may need to lose weight. There's no specific body weight that we're targeting preoperatively, but just a healthy, an overall healthy and functional body that's going to be able to heal well. And in studies, we've seen that being underweight or having inadequate nutrition is as harmful as being overweight. And so both those things would be something you'd want to be considering with your surgeon to optimize before having surgery.
And I wanted to mention the idea of weight loss surgery or weight loss programs prior to joint replacement surgery. It's actually a controversial topic. Generally, we encourage patients to have a BMI below 40. Now, a BMI is something called the body mass index, as you can see on the slide here, and it's just a calculated ratio of your height and weight. As someone who is 200 pounds and 5'3" is not the same body type is someone who's 200 pounds and 6'3". So that BMI has been used in orthopedic surgery as a recommendation to try to be below a certain amount of weight. But when this has been kind of pursued in research studies, there's not a lot of scientific data specifically around weight loss surgery that improves outcomes after surgery. And the thing that we're concerned about primarily is an infection risk, wound healing risk, or even in the setting of placing hardware around fractures, deformities, or joint replacements. Positioning the hardware in the most appropriately aligned place can be harder. So I think that this is a moving topic, and I would encourage you to talk to your orthopedic surgeon or your primary care doctor around your weight goals to make sure that you're healthy. Because it's really been shown that actually maximizing and optimizing your medical problems, such as blood pressure, nutrition, cholesterol, and diabetes, is probably more important and more effective than simply losing weight alone. So something to keep in mind. And now, as you also hear in the news media, that there are a lot of newer weight loss drugs that are both effective at losing weight, but also may put you at increased risks for anesthesia and certain surgeries. So it's a complicated topic, and I would encourage you to talk to your orthopedic surgeon about it.
That was a great segue into our next slide on nutrition. What Dr. Birch was hinting at, this obviously affects multiple health conditions. And these are our building blocks for healing. So depending on what surgery is being considered, you may need to heal bone, muscle, fascia, subcutaneous fat, and skin. And so building blocks for all those layers. Foods with high vitamin C content support collagen formation and activation. Calcium and vitamin D support bone healing. And adequate protein intake is important to think about for healing all those layers. So a well-balanced, broad diet is very important in the peri-op period. Diabetes is another crucial area to optimize if you have this diagnosis. The hemoglobin A1C, which is a reflection of the level of glucose control over the past 3 months. So a pretty broad measure, more so than the spikes of the day-to-day blood glucose numbers. This is telling us what is the average level of sugars the body has been seeing. Ideally, we're looking for a target hemoglobin A1C below 7, definitely below 8 for elective surgery. And this is to reduce risk of all kinds of issues, including infection, wound healing problems, difficulty healing bone. And so this is something that if you do have diabetes, your orthopedic surgeon certainly will be taking into consideration in the perioperative period. Like Dr. Birch mentioned earlier, our goal is to reduce or avoid opiates in the perioperative and the preoperative period if possible. When someone is on chronic opiates, you do build up somewhat of a tolerance, and that makes it more difficult for us to control pain in the postoperative period, as well as intraoperatively. It requires deeper anesthesia and more anesthetic to get control of the pain. And so as much as possible, we know, sometimes it's not possible to completely wean off something that you've been on for a long time, but as much as is possible, transitioning to other medications, like some of the over-the-counter medications we mentioned, different supplements, different, maybe trying bracing to control pain and transition away from opiates, definitely makes for a smoother post-operative recovery. Smoking cessation is also crucial. Typically, we're hoping patients can cease permanently, but at the very least, we're hoping that we can get a 6-week window before surgery and at least a 6-week window on average after surgery to get through the peri-op period. Stopping smoking improves wound healing, reduces infection risk, and it increases vascularity and perfusion of the bone. So it helps heal all those layers to not have that smoking exposure. Maintaining dental hygiene, so obtaining any major dental work. This is mostly applicable to joint replacement surgery, so total hips, knees, shoulders, ankles, less so for something like an ACL surgery or bunion surgery, but looking to have any major dental work completed before a total joint is implanted. The reason that's a consideration, you may wonder, well, how are teeth and joints connected? It's because when major dental work is done and when teeth are clean, when there's a cavity, bacteria are introduced into the bloodstream, which perfuses the joint. So the thought is that they can seed the joint and potentially cause a joint infection. So ideally, if you can have that done before your joint surgery, that would be optimal. We're going to move on, continuing to talk about things you can do prior to surgery, from medical optimization to some lifestyle optimization tips that we have found made our patients' lives easier and smoother in the perioperative period. Starting with family and social support. So if you're having orthopedic surgery or considering orthopedic surgery, it is time to rally your family and friends. You want everyone around you, you want your neighbors to know, you want everyone to know that you're having surgery, and it's your time to call in your favors. This is not only who is going to give you a ride to and from surgery, it is planning preemptively for things like who is going to walk your dog. What's that going to look like? Who's going to be watering your plants? So just enlisting support for all the different things you may not consider in your day-to-day life that will be harder after a major orthopedic surgery affecting your extremities. Along those lines of gathering family and friend and neighbor support is making a specific plan before surgery about how you're going to be recovering after surgery and where you'll be doing that. The time to be making that plan is not after surgery in the recovery room. You want to have a bulletproof plan set up with your surgeon and with your team. Are you going home? Are you going to be going home perhaps with a home health nurse? Or will you be going to a skilled nursing facility? Increasingly, orthopedic surgery is done on an outpatient basis where you're not spending the night in the hospital. And so that does often require resources to be set up in advance, like home health care, like arranging medical equipment in advance, getting meals set up in advance. So again, the more of this that can be thought through and planned for, the smoother surgery and smoother your recovery will be. Part of that perioperative plan for going home is thinking about what medical equipment you are going to be needing. So some of this is based on conversations you'll be having with your surgeon about what kind of restrictions you might have. Are you going to have a restriction on motion? Are you going to have a restriction on weight bearing? Those things will influence what you need to safely get around your home. And you want to be able to gather these pre-op. There may be things you can borrow from friends. There's things you can rent, such as the knee scooter, where you're rolling on one knee. Those are often rentable from medical supply stores, so you don't have to buy them. In Santa Barbara County, we have the wonderful Visiting Nurse Loan Closet, which is like a lending library for free medical equipment. I've also had a lot of patients have success with Facebook Marketplace and Nextdoor. And you really want to get into the nitty-gritty, thinking through every part of your day. So thinking about, okay, how, if I have a splint on my leg, how am I going to shower? Because then you're going to be thinking, well, I need to, if I don't have a bench in my shower, I may need to get a shower chair. And I need a way to keep that splint dry. So actually getting a shower bag. from the drugstore. So really kind of thoroughly going through your day. The goal is to minimize how much running around you have to do after surgery, and to be doing all of that before surgery.
All right, we're going to transition away from things we can do prior to surgery to talk briefly about how to make a decision for surgery. And Dr. Thomas and I are in agreement that, we don't treat x-rays and we don't treat MRI findings, but we treat patients. And so we spend a lot of our day just counseling patients on whether or not their findings on their MRI or the severity of their disease on their x-ray is relevant to their life and their quality of life. So I found it helpful to ask these 3 questions. Are you having pain every day in the affected area? And is the problem affecting your quality of life? And is it limiting you from doing the things that you want to do? If patients are confident in saying yes, yes, and yes to those 3 questions, and the imaging does support the pathology that's their complaint, then usually they're an appropriate surgical candidate.
I would echo all of those questions in agreement with the focus on what's meaningful for patients' lives. I think it's one of our favorite things about orthopedic surgery is that we get to spend our days hearing about the hobbies and activities that are meaningful to patients, that bring them joy, and helping decide when those things have been compromised enough that it's time to proceed with surgery.
So during surgery, we're just going to touch on a few things and maybe more relevant for a question and answer session, but starting with types of anesthesia, things we talk about regularly, there are generally 2 main types of anesthesia care during an operation: general anesthesia and neuraxial anesthesia. General anesthesia is using an inhaled medication through some type of breathing device that keeps you unconscious and pain-free during surgery. Most of the time, this does not require a tube to go down into your throat, but actually allows for a breathing device to sit in your mouth on top of your tongue to keep you comfortable during surgery. Neuraxial anesthesia, also known as spinal anesthetic or an epidural anesthetic, is when a numbing medication is put in the spinal canal area that makes your legs go numb. And so you don't feel anything. You are usually then given a relaxation medication to keep you comfortable and keep you sleepy during surgery, but you're not getting an inhaled general anesthetic gas. Both are very safe and effective. I tell my patients all the time that although anesthesia is a serious and common concern for most people, that it should be at the bottom of the list as far as risks go, because anesthesia is very, very safe. The choice is really between the patient, the surgeon, and the anesthesiologist. Some of it is usually affected by the type of surgery that you're having, or the location of the surgery if you're having. Like, are you planning on going home that same day, or are you planning on spending the night? They both have pluses and minuses with respect to certain types of pain control or controlling of nausea, but generally around joint replacement, we seem to be doing more and more spinal anesthetics, where around fracture care and other foot and ankle deformity, we often do more general anesthetics. And this is the type of medicine that's delivered to you in the very beginning of the surgery before you, quote unquote, go to sleep. Nerve blocks are another type of anesthesia, but it's really peripheral anesthetics, primarily for pain control. Nerve blocks are not making you go unconscious, but they may make your nerves go to sleep. So around foot and ankle surgery, many times people get a nerve block that makes their leg not have any sensation or motor function in it, which really, really helps with pain control. But you need to know that after surgery, you're not going to be able to wiggle your toes and your foot's going to feel kind of dead for a bit. Similarly, we do that in the shoulder all the time for shoulder and elbow and some hand surgery. And so these are usually ultrasound guided injections done by the anesthesiologist in the pre-surgery area before you go back into the operating room. Specifically around total knee replacement, it's like an adductor block around the thigh, but there are many, many types of scalene blocks in the shoulder or popliteal blocks for foot and ankle, and it's a conversation you can have with your surgeon in the office, and then again with your anesthesiologist at the time of surgery.
Yeah, and especially in the field of foot and ankle orthopedics, nerve blocks have revolutionized pain control, where I've even done a total ankle recently without needing any post-operative narcotics, because the anesthesiologists are able to identify the nerves in the back of the knee using ultrasound that supply the leg, and using that ultrasound guided needle to place lidocaine or long-acting anesthetics around the nerve, giving in sometimes up to 3 to 5 days of reduced pain. So these have really enhanced foot and ankle surgery. I will also, at the time of surgery, sometimes in addition to or instead of a formal nerve block with ultrasound and having the anesthesiologist block the nerve, we'll do something just called local infiltration, where we'll put numbing medication in and around the incisions themselves during the surgery, again, just to reduce the pain perioperatively.
And these are, there are newer kind of emerging drugs that do what we just described, both put numbing agents around nerves that go to the affected area or put it around the soft tissues at the time of surgery. And there are now these pain control medications that can last for days instead of hours. Historically, we used something like Novocaine or lidocaine for nerve blocks and for pain control in the soft tissues. And just like at the dentist, those tend to last somewhere between 4 to 6 hours, occasionally around the nerve, 12 hours. But there are newer medications that slowly dissipate into the soft tissues over 48 to 72 hours, which often provide really good pain relief for the first 2 to 3 days after surgery. This can be very helpful to kind of get through kind of that first intense transition to home and the difficult time in the first day or two after surgery and controlling your pain.
Like we've spoken to earlier, our goal is always to reduce narcotic exposure in our patients. And so we talk about multimodal non-narcotic pain management. And this is referring both to using multiple classes of medications, so Tylenol plus anti-inflammatories if they're appropriate with your other health conditions, which help with both pain and swelling. Nerve agents like gabapentin or Lyrica that reduce some of the nerve, the messages from your nerves. Anti-spasm medications are often helpful, especially in foot and ankle surgery or with deformity correction where muscles may be irritated by being placed into a new position. All of those are different classes of medications that we can use to control pain, to reduce narcotic use, keep patients comfortable. And in this category, I would also add the non-pill form of pain management, things like elevating, icing like you see here, and then also things like visits from friends, listening to soothing, calming music, being in a beautiful space, things to just help distract and calm yourself in the perioperative period. At Cedars-Sinai, where I trained, they were actually doing really cool research about using virtual reality to reduce pain in the perioperative period with some great success. So anything to take the mind away from the pain can be very effective. So in the OR, in addition to your surgeon, surgery is a team sport, which is another thing we love about it. you will have a whole group of experts caring for you. This is Dr. Birch here with a team of our excellent peri-op nurses at Goleta Valley. And so all of these people have different roles, from the circulating nurse, the scrub tech, your preoperative nurse and postoperative nurse, your radiology technician, the device representative. So there's a whole host of people who are very highly trained, assisting the surgeon and working to get the best outcome. And we're spoiled at Cottage to have excellent team members. Cottage is a magnet for top talent. And we really see that in the quality of the people that we get to work with every day and that we trust with our patients.
So technology has always been an essential part of orthopedic surgery. Back hundreds of years ago, about techniques around casting, now to using robots to perform surgeries. You may have heard many buzzwords just casually, like computer navigation or robotics or patient-specific instrumentation or fluoroscopic guided. And these are all different variations on the same theme. We are trying to utilize tools in the operating room to improve outcomes. And as surgeons, we need to balance time, cost, the potential benefit to using new technologies, and the potential complications that come from using new technologies. So there are a lot of different terms that I think is probably best to discuss one-on-one with your surgeon, talking about the particular type of procedure that you're pursuing. There does seem to be a lot of buzz in the news media about robotic surgery, around spine surgery, shoulder, hip, and knee replacements specifically. And robotics in orthopedic surgery have been around for multiple decades, probably greater than 20 years. And it's an evolving tool in the operating room. It used to be quite rudimentary, and it's become a lot more sophisticated. And we're still trying to figure out if it's actually helping the patient, meaning improving patient outcomes with respect to function and pain and satisfaction after their surgery. So Cottage has all of these technologies available, and multiple surgeons in our community that operate at the hospital use different levels of technology in the operating room. Many people are using computer navigation and robotics to perform surgery, and it really depends on your surgeon, on the type of procedure you're having, and maybe whether or not it's appropriate for you. So transitioning to after surgery.
So after orthopedic surgery on your extremities, you will likely have restrictions on either or both weight bearing, so how much you can load that extremity, and then motion, how much you can move the extremity. You need to follow these instructions. The last thing you want to do is undo the results of a complex, well-performed surgery by lack of compliance. And if there's any shadow of a doubt in your mind about if you're allowed to do something, please ask your surgeon. They would always rather you reach out and ask them and call the office, call them, than do something that could compromise your outcome. Next slide. Physical therapy will also likely be a part of your postoperative recovery. If you have done preoperative PT, you may have a relationship already with a therapist that you want to continue working with, and who knows you and your musculoskeletal system, kind of knows where your baseline is and what your goals are. Your surgeon will likely will clear you to start physical therapy and give you permission to start it. We'll write the order for physical therapy so that it's covered by your insurance. And then we'll give your physical therapist specific instructions. And in our community, it's great because most of us are pretty closely linked with the physical therapist in the community and can communicate easily back and forth as the restrictions on what you can do evolve, or if there are any questions and concerns. So ideally, your surgeon and your physical therapist have a good working relationship and can communicate as you progress along.
And I just give a plug back to pre-surgical planning. Post-COVID in the Central Coast, physical therapy has been very impacted for a number of reasons. And so it can be difficult to plug into a physical therapist. So make sure you plan, talk to your care team, and try to get post-surgery physical therapy set up prior to going into surgery.
That's a great piece of advice.
So on to lifestyle expectations. Of course, we needed a picture of a pickleball court. I regularly get asked about limitations after surgery, and there's really not a lot of scientific studies to help us answer these questions. I would say specifically around shoulder, hip, and knee replacement. I think there is actually more in the foot and ankle world, but we still have really kind of limited scientific evidence to answer questions about what specific types of sports or activities are available after surgery. So again, it's a question with your individual surgeon. But remember, the goal of surgery is to increase your activity level, reduce your pain, and improve your lifestyle. So generally, to questions about, can I do this, doctor? The answer from me is usually yes. Many patients after joint replacement surgery or fracture care are back to playing pickleball, playing golf, hiking, surfing, cycling, skiing, playing doubles tennis, things like that. Not everyone reaches their maximum goals of the things that they want to pursue, but many, many, many people do. And that's why after a lot of our surgeries, the satisfaction scores 6-12 months out are in the 90 percentile. So I don't have any specific restrictions after hip and knee replacements, except that you should do things within reason, be careful, and try to avoid regularly running multiple miles on hard surfaces for exercise, because it's probably not going to do you well in the long run. Anything to add, Dr. Thomas, about that?
No, I think you really captured it. I don't have any in the distal lower extremity, foot and ankle. I don't have any specific universal restrictions. It really is dependent on the patient and the surgery. I think in general, total ankles are a little bit more delicate than total hips and total knees. And so I do encourage my patients to avoid long distance running. Light jogging is fine, brisk walking, but prolonged running is, and pivoting, cutting, like basketball, singles, tennis, are often things that will break down a total ankle implant more quickly than I would want. But it's not a universal restriction.
Excellent. All right. Well, thank you for your time. We'll open it up for questions.
All right. Thank you, Dr. Thomas and Dr. Birch, for that very interesting presentation and information. We'd now like to move to the question and answer session. As a reminder, please put your questions in the Q&A box at the bottom of your screen, and I'll read them off to Dr. Thomas and Dr. Birch. We have a few questions, so we'll do our best to get through as many as possible. So one question we received is, has research shown that platelet-rich plasma injections are effective?
That's a great question, and I think we'll both have some joint-specific perspective on that. I'll start with the foot and ankle for this. And I would say both yes and no. Our research is evolving on platelet-rich plasma. And in certain pathologies, it has been shown to at least be as effective as the traditional steroid injections without some of the negative effects. So in tendon pathologies in the foot and ankle, like Achilles tendinopathy, and especially in plantar fasciitis, there's some pretty good data that platelet-rich plasma can be effective. In ankle arthritis, however, there was recently a great paper in JAMA that showed that it really wasn't helpful for that, for ankle arthritis. And so I would say distally, ankle and below, we have good data that it's helpful for tendons, but not so much in the joint. And then I think that might be different than what Chris has to say.
Yeah, the scientific evidence has simply been mixed. There have been some clinical trials that have shown it to be very effective at reducing pain out to 12 months. And when compared specifically to hyaluronic acid or to cortisone or to placebo, it seems that PRP does a better job at reducing pain for a longer period of time. But anecdotally, I tell all patients that these things, it's not covered by insurance and it can be very expensive. And I encourage people to try it if they're trying to avoid surgery, but that there's no guarantees. And we're actually not in a place in 2023 where we can say, well, for your demographic and your problem that you should specifically have this type of injection. So I have many patients who find PRP to be more helpful than hyaluronic acid, and vice versa. I've had many think that the PRP is not helpful and that the hyaluronic acid or the cortisone or the Toradol or the other type of injections have been more effective. So I do think we know that the more significant the arthritis or the higher severity of the disease, the less likely it's going to give you long-term benefit.
I would add that, and then, oh, go ahead, Chris.
Well, just lastly, to define the word effective, PRP, I think, is helpful at reducing pain. There's a lot of talk in the lay literature about whether it rebuilds cartilage, whether the mesenchymal stem cells that are in the PRP are helpful at healing soft tissues injuries like meniscus tears. And I think that the data is quite limited, and we should be cautious about that we're not trying to cure arthritis or heal a tendon or meniscus problem. We're trying to use it as a powerful anti-inflammatory.
And I was just going to add, because you mentioned hyaluronic acid in the knee, the data similar to PRP in the foot and ankle, the data on hyaluronic acid is evolving with time, where we are actually seeing some really promising results with hyaluronic acid in ankle arthritis. We're hoping that soon insurance companies will start covering hyaluronic acid in ankle arthritis, similar to the way that they're covering it for knees. Currently, it's not covered by most insurances, although I have had one or two incidences where I've been able to write letters of appeal based on some of the new data, but that is something we're hoping will change in the next few years.
Awesome, thank you both for that. Next question is, we know that a balanced diet is helpful, but are there any foods that are known to promote joint pain, such as red meat?
I believe that diet has generally been debunked when it comes to its role in joint pain, specific to the question about maybe uric acid levels or gout and red meat. It tends to be more familial and more genetic than it does diet related. I'm not a nutritionist or a dietitian, so I can't speak as an expert in that area, but I can speak anecdotally that patients who have pursued anti-inflammatory diets, such as a gluten-free diet, have found it to be very effective to reducing inflammation, more so around soft tissue injuries like tendonitis and bursitis, but also around joint pain.
I would say I've seen the same thing anecdotally in my practice with reducing sugar, reducing alcohol, some of those reducing red meat, the general anti-inflammatory principles, I've seen to be very helpful.
Great. And another question we received is, at what point does one decide that it's time for a knee replacement instead of just controlling pain?
I think that's what we were getting at earlier, talking about what your lifestyle goals are, how much it is affecting your quality of life, how much does your knee drive your decision making about your activities during the day versus your other priorities in your life, and then how much pain you are having, and is it controllable through non-surgical options. But if you have persistent pain and you have moderate to severe knee arthritis, and you really feel like the knee is driving your life, you're not driving your life, there's a very good chance that you would be a great candidate for surgery.
Perfect. And then how often is it safe to use cortisone shots for an arthritic knee?
I guess I'll tackle that one. The timing and frequency of cortisone shots is really more based on tradition in clinical medicine than it is based on something that happens at 2 months, 3 months, or 4 months. But the general recommendation is to try to limit it 3 times a year and no more than 4 times a year.
And then, Chris, I know also for me in the ankle and for most of the joint surgeons, you're also thinking about if you think you're going to be needing joint surgery, you wouldn't want to do a steroid injection within a certain time frame of that. And for me, it would be 3 months before a total ankle surgery. I'm assuming it's the same for you in the knee or hip.
Yeah, similarly, to reduce any risk of infection, we want to wait 3 months from the time of the most recent injection. And that is extended in the hip and knee replacement world to not just cortisone injections, but also hyaluronic acid injections. Yeah.
Okay, perfect. We have time for one more question. So the question is, what is the average time a knee replacement will last?
Our historical data is that 80% of knee replacements will be well functioning at 20 years. So there's not like a lifespan of a knee that it does well and then quits working. But the number one cause of knee replacement failure is that the parts are loosening from the bone. And so that happens over time, but there's a very good chance that 8 out of 10 knee replacements will be doing well at 20 years, and 6 to 7 out of 10 knee replacements will be doing really well at 30 years.
Great. Dr. Thomas, do you have anything else to add?
No, the data on total ankles is still evolving. They're newer technology in terms of our latest iteration of implants, but the survivorship is similar and on similar trajectories at 20 and 25 years.
Perfect. Alrighty, well, that concludes our Q&A session. So thank you both. And thank you everyone for your questions and for joining us this evening. As a reminder, Dr. Thomas practices out of the Ryu Hurwitz Orthopedic Clinic in Santa Barbara, located at 2936 Della Vina Street, and you can reach her office at 805-963-2729. Dr. Birch's practice, Alta Orthopedics, is located at 511 Bath Street in Santa Barbara. You can reach his office at 805-963-9377. He also has a location in Solvang at 2027 Village Lane, Suite 101, and you can reach that office at 805-688-8821. As a reminder, this presentation is being recorded and you will receive an email within the next week with a link to view the presentation and PowerPoint slides. Please note that a brief survey will appear after this webinar closes, and we'd love to hear your thoughts. This concludes our program for today, so thank you again for joining and have a happy and healthy rest of your evening.